Welcome to welcome to our first episode of the Manitoba Adult Concussion Network podcasts, MACN for short. My name is Patrick Fredette, and I will be hosting our first episode on topics related to concussion, where we will interview healthcare providers and specialists who treat concussion on a regular basis. Many of the subjects that we would like to approach with these podcasts, we will hope to give you, the listeners, the best evidence and also demystify some of the difficult subjects that surround concussion. Our first guest today is Dr. Neil Creighton. Dr. Creighton is the director of the Sport and Exercise Medicine and Hand-on Skill program at the University of Manitoba at the Legacy site. He is also assistant professor at the University of Manitoba and also adjunct professor at the School of Kinesiology and Allied Health at the University of Winnipeg. He is also team physician, and that would be great because now we know he has 2 Grey Cup rings, and we could talk briefly about that. But you'll be taking us through a talk on some chronic traumatic encephalopathy, better known as CTE. Dr. Creighton, tell me a little bit about yourself and how we eventually got interested in this interesting CTE subject.
Hey, Patrick, it's really nice to speak with you tonight. You should all know that I think Patrick's a very good friend and one of the best sport medicine clinicians in our province, so it's a thrill to be able to speak with him. The area of CTE is certainly an area of great controversy. You know, we don't have many medical conditions that you make movies about. Our friends from gastroenterology would wish they could make a movie about colon polyps, but they don't. They've made movies about this thing called concussion and CTE. So CTE, chronic traumatic encephalopathy. So this is a condition that has been seen largely in professional athletes. It's about 75 years old. It was originally referred to as dementia pugilistica, or a series of kind of cognitive difficulties that were present in people who've been boxers. It was also called boxcar brain for people who had been hobos and jumping off trains, getting brain injuries, and then having significant impairment in their later life. And most recently, it's been popularized by a group out of the Boston, a woman by the name of Anne McKee, who's a neuropathologist, who rose to considerable acclaim in the kind of 2010s, publishing a series of cases of professional athletes who had this basically a brain wasting degenerative disease. So that has kind of begun the so-called modern CTE epidemic.
Wow, and they also use the term punch drunk. We've heard that go around also, correct?
For sure. So I guess the key thing that the name would indicate, this is from brain trauma, and this requires multiple episodes of brain trauma. The Boston University website itself says that 1 concussion will not lead to chronic traumatic encephalopathy. It's their position that literally thousands of brain injuries or kind of subthreshold head shake episodes are required to cause this, really only in the realm of people like football players, professional football players, boxers, those who expose their brains to repetitive trauma.
And so right now I think you're presently working on a concept paper, and I think the title is, correct me if I'm wrong, it's a CTE, or chronic traumatic encephalopathy. Do we know the probable cause? And is it time for a new idea? I really like that type of title. So tell me a little bit about this concept paper you're working on.
Yeah, Patrick, it was kind of an example of serendipity. I do some work at a homeless mission, and many of the people there, unfortunately, use methamphetamine. And I see patients who've been using methamphetamine as a drug of choice as part of their substance use disorders, people trying to eliminate pain in their lives. And we won't get too far into that conversation tonight. But I was looking at some of the brain manifestations of methamphetamine, because when I see these people at the mission, they're like zombies. It's very, very sad. And so I was looking at some of the neuropathology around methamphetamine use, and I was really shocked to find several papers that showed that methamphetamine use leads to basically an identical picture in terms of the neuropathology seen in the brain. So you see these kind of proteins called tau proteins scattered in various places throughout the brain, kind of inflammatory changes, degenerative changes. Then the one researcher said that they were indistinguishable from a brain that had multiple episodes of trauma. So I started looking at the different types of drugs that might find their way into a professional athlete system. And obviously, anabolic steroids would fall into that class. Weaker amphetamines than methamphetamine would fall into that class. Opioids would fall into that class. Cannabis would fall into that class. And many of these drugs lead to clinical pictures in their extreme that are almost identical to CTE. So I wonder whether this is just trauma or trauma as well as other chemicals that might be causing difficulty especially in the professional athlete's brain. There's an excellent paper that says that trauma is required but not sufficient. So trauma is necessary but not sufficient to develop CTE. Something else is required. Is that genetics? Is that substance use? We don't really know. But I found it a very fascinating area of literature.
It's also interesting how, when we look pathology-wise, the tau proteins don't always accumulate in the areas where the true trauma actually happens, and it can actually be in other parts of the brain. Is that correct?
Yeah, it's correct. And we must say that the neuropathology of CTE really has to be in its infancy because there's still really less than 1,000 cases that have been identified, even by the Boston group. So this is not a common condition where neuropathologists would look at something like skin cancer, where they'll see, thousands and thousands every year in one pathologist's experience. So
do we have a true incidence number, like if you compare the professional athletes versus the general population?
So the Boston group has about 1,000 brains that have been donated to it. And my understanding is that about 2/3 of those have been identified as having CTE. So worldwide, really in the history of sport, we have less than 1,000 cases identified. The literature has kind of kept track of this. So this is an exceptionally rare condition as it's been identified to this juncture in medicine.
Oh, interesting. You also propose in your in your concept paper, maybe a change in nomenclature that might reflect this a little bit better. Tell me a little bit how you came around to wanting to think about a new type of nomenclature.
So I think it's really to help with a public health initiative surrounding what would be deleterious health habits that some athletes, particularly professional athletes, have. And this would be related to substance use disorders and then the use of kind of doping products. So if you look at the data about people who've used anabolic steroids for a long time, the people who do poorly and develop basically encephalopathy, the clinical picture is essentially identical to that of CTE. Same thing with a person who's had an opioid use disorder for many years. You might imagine a person who's been living on the street, a heroin addict, for example. Unfortunately, we have lots of neuropathology about their brains and their behavior. So the behaviors of people with encephalopathy from substances are almost impossible to sort out from the behaviors of those who have chronic trauma as the only source of difficulty.
Right.
So we know that up to 50% of athletes use amphetamines to increase their cognition, their energy levels. These are strong stimulants. Many people use amphetamines to treat underlying diseases like attention deficit hyperactivity disorder. Unfortunately, many people in sport, especially professional sport, use opioids to deal with the chronic pain of being a professional athlete. 70% of NFL players report using regular opioids, and obviously opioid use disorder and substance use disorders were very prevalent in the initial cohort of people identified as CTE. Mike Webster was the so-called patient zero, a professional athlete from Pittsburgh that was basically the patient who was the concussion movie was built upon. And his story is a very sad story where he is identified as having CTE and was basically homeless and a substance use disorder sufferer. So we don't know the direction of causality at this point as to whether this is only from substance use, whether people who have CTE start using substances, whether substance use disorders facilitate the progression of CTE. So given these clinical questions, I think having only trauma in the nomenclature of the disorder might stop efforts at preventing other behaviors that could certainly reasonably contribute to this disorder. So making sure athletes are very well aware of the negative consequences of regular use of opioids, certainly in the use of amphetamines that's not prescription in high doses, especially if they're doing it in kind of an illicit fashion, or other medications that may contribute. Anabolic steroids for sure leads to long-term neuroinflammation, which is kind of one of the markers of CTE.
So what is this new idea that you're proposing? Or what is this new nomenclature? What is it called?
Well, I'm an acronym person, and I really think in acronyms. It just came to me this idea. So idiopathic degenerative encephalopathy of athletes. We don't know the cause of this condition, which is the term idiopathic. This is a degenerative brain wasting disease. So I like that term, degenerative. Encephalopathy is obviously the same. And then this is mostly in the athletic population. It does occur in military veterans who've had multiple blast injuries, and people who've had significant brain injuries. But the vast majority of these people are really professional athletes, and a high percentage of those are professional football players. So this idea, IDEA, idiopathic degenerative encephalopathy of athletes.
Great. Yeah, because right now, so you have trauma, that's a common, but we're not sure if the trauma is actually first, or is it actually the presupposition or the predetermined, either genetically or the products that they're exposed to. So that makes it really, we're not certain of a lot of information.
Yeah, so I love this statement, and it's not mine, it's from a different author, that trauma is necessary but not sufficient. And if it's not sufficient, there must be something else. Is it medically reasonable to look at biologically plausible other etiologic agents? And I think in the sport world, it's very plausible that the use of amphetamines, anabolic steroids, and opioids, and especially the use of all of them together. You can imagine a person who's regularly using anabolic steroids as part of their career to increase muscle mass and strength, who uses amphetamines at game time to give them that competitive edge and increased energy, and then after the game gets really hurt and uses opioids to help their pain. And unfortunately, there are people who develop opioid use disorder where they're taking larger sums of opioids that, again, would further increase their risk. So that's my concern, that this kind of unholy triad of opioids, anabolic steroids, and amphetamines might make a brain very, very much at risk for the development of chronic traumatic encephalopathy.
So at this stage, if I understand, the only way to make a diagnosis of CTE is post-mortem, correct? Is there any research or is there any advancing on, besides doing this post-mortem and analyzing the brain, do we have any insight into how we can maybe diagnose this before?
Yeah, Patrick, that's a good question. This is something that is at this point, gold standard would be a neuropathological evaluation of brain tissue, essentially post-mortem. And I think that that's the key point that the Boston University group would suggest. There are some people who believe that special brain images, PET scans, et cetera, might be able to elucidate this diagnosis in a living person, but I don't think that has widespread kind of support at this time. So it is a post-mortem diagnosis, which creates lots of terrible uncertainty for people who are experiencing some of the symptoms. And the symptoms of CTE are widespread in the general population. Anxiety, depression, mood disorders, impulse control disorders, sleep disorders, confusion. Depression can present in almost the exact same way as CTE. Depression, 1 in 3 of us will experience. CTE, less than 1,000 in the history of the modern world. So,
how do we make sure at that point, though, then the attention drawn to CTE, that the public doesn't get overwhelmed with this and think all these symptoms that overlap, that they might actually have CTE.
I think that I had a patient last week who came because they were afraid they had CTE, probably had 6 or 7 concussions playing junior hockey, 40-year-old executive now, having a bit of trouble with paying attention, what he thought was memory disorders. And at the end of the day, we did a test called a PHQ-9, which is an inventory for depression, a very basic inventory. And he scored in the severe depression category. And I didn't believe that his number of concussions would be a probable source for a very rare condition. I thought that he probably had a very common condition. And, I know, Patrick, one of your favorite words is zenning these people. Try to help them, hey, man, I don't think this is CTE. That would not be common. That would be exceptionally rare. Could this be just simple depression? And, he started crying, and he thought that, yeah, that probably was what it represented. He'd had a family history of depression. And so the good news is that primary care clinicians, especially primary care physicians, are very, very well versed in the assessment and diagnosis and treatment of people with depression and mood disorders. Family physicians provide the bulk of mental health care in our province. And so they can all make the diagnosis of depression, whereas CTE can only be diagnosed by a neuropathologist post-mortem. So I think we tell people what's common is common and what's rare is rare. And that helps many of us.
It does. So reassuring people that the likelihood is extremely low and that we have no way of diagnosing it at this point, and that we have to move forward with life and encouraging them and getting them to use a healthy lifestyle and continuing in that direction, correct?
Absolutely.
Yeah. It's International Month, I think, or there's a lot going on an international basis right now with CTE. Can you give me a little bit of insight on that?
Well, I think that there are still people who spend a lot of their entire research life looking at this condition. And I think it's really important to identify, why does this condition happen? What are the risk factors? How can we prevent it? And I think most people are taking brain injury and head injury very seriously in the world of sport, and doing everything in our power to minimize the risks to competitive athletes, to exposure to head injury, and decreasing the incidence of that head injury. With the Blue Bombers this year, we had very, very few concussions. And that's thanks to simple things: no contact during practice, don't concuss your teammate, things like that. And then tackling rules, penalties for egregious hits to the head in football, and other sports have similar legislation to minimize the risk of such head trauma. So having a month like CTE month is wonderful from that perspective. I'm concerned that if a patient focuses too much on this condition, it can create a great deal of anxiety. The condition is already associated with anxiety. And from my experience in healthcare, I don't think this is a common condition that most people should be worried about, especially not the recreational athlete who's had a handful of concussions and isn't getting exposed like a football lineman would be to literally thousands of head contacts per year if you're a lineman in the NFL. So I think we are not comparing apples with apples. I support ongoing research into CTE, but I really think that we as healthcare providers need to help patients understand this is rare, and this is not something most of us should be worried about.
That's great. I hope it's podcasts like this that really help to see clearly and have a good understanding of these concepts that will hopefully help for our allied health, and also especially for those who suffer from concussion or any minor traumatic brain injury. Well, were there anything else that you want to add to our discussion today on CTE?
No, I really enjoyed this, Patrick, and I think that we've touched on the major areas surrounding this condition, and I really hope that people will be able to feel reassured that this condition is widely respected by those of us who treat a lot of concussion patients. We never want to see anybody go down this path, but it is an exceptionally rare condition. And many people can have treatable other conditions, especially depression, anxiety, that with some mental health interface with their family physician, perhaps working with a psychologist, or even better, a neuropsychologist who can do specific tests to, again, elucidate other cognitive problems that could be part of this condition. I think that people could be well served by getting care, and that care will often have a very treatable condition and not be something as devastating as CTE would be, or maybe we should say as IDEA would be.
Right, exactly. Well, Neil, I'd like to thank you for this marvelous talk today and really helping to clarify the many concepts surrounding CTE. I wish you a lot of success with this new concept paper and hope to have you back on soon. Thank you very much.
Thanks, Patrick. I enjoy speaking with you.
Awesome.
Hey, everybody. My name is Neil Creighton, and I'm a sports medicine physician here in Winnipeg. And I'm here on behalf of the Manitoba Adult Concussion Network. The Manitoba Adult Concussion Network has been around for about 3 years. And our goal is to help Manitobans prevent concussion, be treated by experts when they sustain a concussion, and ultimately have as little impairment in their lives related to this important diagnosis. MACN is a multidisciplinary group of people, and I have the great pleasure to talk to its founder. He's our papa. This is the doctor who really worked behind the scenes with a bunch of clinicians, busy people, but Patrick was able to get all of us into a room, and I think really did a great job getting MACN off the ground. So Patrick Fredette is a sport medicine physician. He practices in St. Anne, Manitoba, and is really a staple in that community. He has a very extensive sport medicine practice and provides care to athletes really throughout the country. Still a good old family doc, and you might find him working in the emergency of the St. Anne Hospital, saving people's lives. A veritable dynasty in his family of physicians. His wife is a physician, and his kids are physicians, and really doing great things in the medical community. Patrick himself is an athlete. He's a high-level triathlete and was a high-caliber university volleyball player. But most of all, Patrick's just a good person. So I'm really thrilled to be able to introduce my good friend, Patrick Fredette, the original founder, the papa of MACN.
Wow, thanks for that intro, Neil. I really appreciate it. It's been my pleasure and an honor for me to be involved in my community, and also sports medicine is such a nice background to be able to help people and also deal with elite athletes. So I've been really, really blessed, and I'm very fortunate and thankful for that. And I've been able to meet wonderful people, especially our group that we were able to form for the Manitoba Adult Concussion Network. Basically, you gave some really good insight right off the hop. This is a group of people. It's a bunch of allied health. And I think sometimes in 2017, it came about me just kind of overthinking maybe a little bit that we had developed a program, not myself, but we developed a program for pediatrics and concussion, and that opened up around 2014 with the Pan Am concussion program, and it was children mostly, with Dr. Michael Ellis, who's doing just a fantastic job with concussion for children, and really leading the country in some of the stuff that we're doing there. And but I started seeing in the rural area, and our adults really were falling through the cracks and not being able to have concussion treatment that is straightforward and basic. We were developing protocols that we weren't applying properly, and I was finding a lot of adults were falling through the cracks. And so I think I started off with a phone call with you. We sat down, we had lunch, and we said, how can we do something for adults? And then I also spoke with Glenn Bergeron from the University of Winnipeg, and then I met Michael Ellis with the Pan Am program. And then we just added on amazing people through our whole group right now. And we sort of formed this really tight-knit group. And I met with Peter Nemeth, who's, does primary sports at the Pan Am. And we got Ed Pilot, who is primary care sports physician and works with our national athletes. We also initially had Kurt Kauenhofen. And then we added on with fantastic help, Leslie Ritchie, who does our neuropsychologist. So this is kind of the group we put together, and it's been marvelous since I think early 2000 or late 2018, right? That was our first time we got together.
So Patrick, I'd be interested to hear an example of how a patient of yours kind of fell through the cracks before he came to you. Maybe give us some understanding of a patient's experience and why you thought an organization like Mackin was required to fill some of those gaps. Could you give us an example of a patient that looked like they were struggling to get the right treatment for concussion?
Yeah, and we still have it ongoing today, and it's all through our country right now. Is what would happen is a patient, whether it's an adolescent, a child, but specifically in the adults, that they would hit their head. A lot of them would make their way either through walk-in or through the emergency department, and then they would be diagnosed with a concussion. And then because of lack of maybe ideal resources, these people kind of just try to get in with their family physician who may or may not have experience with concussion. And we're finding a lot of these people now having chronic symptoms that were developing. So that was one group that I was finding, is that I was seeing some of these in consults of people that had chronic symptoms that were developing because they had a concussion and we didn't give them good basic advice right off the hop, and now they're in 3-4 months in their concussion. And that was one subgroup that I saw. Another subgroup would be people that really had no treatment at all, and we're just seeing later on for persistent symptoms that were going on, and they were also another subgroup. And I found that the resources we had out there, although we're trying to educate primary care providers on the appropriate way of treating it, I find that if we were seeing these patients, many of them had multiple tests already done, when all they needed was simple, good, wholesome advice of how to reintegrate activity and how to treat each aspect that they were having. And I thought there would be better ways. And I said, we got to get together and try to do something for these patients.
What would you say would be the most common, we won't call it an error, but what would be the most common bit of advice that patients get that you would like to see change? So that person, he's been concussed, he's gone to the emergency room, they're convinced that he hasn't had a brain bleed, had a CT scan, everything's cool from that perspective. He hasn't broken his neck, but he feels very poorly, and he comes into the family doctor's office. And at that first encounter, what would you see as some of the negative pieces of advice that a person like that might receive from someone who doesn't see a lot of concussion?
Right. Good question, because I find that if we don't initially, one, reassure the patient, because the vast majority of symptoms, once we've assessed the patient, we know they don't have something significant, they need to be reassured. They need to be reassured, and they need to be told that they need some very limited rest and then reintegration into activity and getting going again. And I think the biggest problem I am seeing is people that are told, well, you need to rest until all your symptoms are completely gone. And then if they have a little bit of headache left over or some neck pain or they're a little bit dizzy, they'll be resting 3-4 weeks sometimes, and they haven't initiated any activity yet. And then they've been off work for long periods of time because they have some persistent symptoms that haven't been approached. So I think the number one thing I'm seeing is getting them to rest too long. And it's clear in the guidelines now for concussion that we want to activate these patients as soon as it's safe and progressively get them going again.
So Patrick, it's my understanding that rest used to be really endorsed as a treatment for concussion. When did that change, and what prompted the change?
Well, certainly in the last international conference that was done in Berlin at that point, it was felt that the physical activity was becoming more and more of an important factor of getting people back into light light activity and building up their tolerance with it. And it's probably one of the number one factors for improving their concussion symptoms. The second factor I feel that is the most important is probably reassuring the patient. The anxiety or the depression or any other symptoms that are underlying that are creating that can really maintain the symptoms longer. And a good understanding of the pre-existing health issues that a person has can really help to open doors on proper treatment for this. It's not complicated. Basic concussion treatment I find is very simple and straightforward, but it can be made to sound very complicated, and it's not.
Okay. So the evidence changed and physical activity became kind of more accepted and more appropriate early in the management of patients with concussion. How is Mackin trying to share that with the community?
Great. Yeah, I think work with the other experts. So Mackin, again, we are sort of a grassroots type of group that came together. It's not for profit, and we're healthcare providers kind of helping these patients and the family that are affected by concussion. So we wanted to create a network. So our group of initial practitioners of Mackin, Manitoba Adult Concussion Network, they come from a variety of healthcare disciplines and share a common mission. But what we wanted to do is branch out and educate and include a network throughout the province. And this network practices the same approach to concussion. And I find that if we have vestibular therapists or physiotherapists or any neck therapists or counselors or psychologists, there's a huge team we can build, but every concussion patient doesn't need all of this. But we need to be able to recognize when, and we don't have to have this all in one building. This can be a network that is spread out throughout the provinces because some areas have very limited resources. So to create a clinic that has everything in it is actually, I find, can over-medicalize the poor patient by having to do every treatment on them when it's not necessary. So I find that Mackin has been a good, strong voice of creating this network and disseminating basic, good treatment for concussion.
I've been present at some of your webinars. How have the webinars been accepted in the community, and what do you have planned for the future?
Yeah, we launched an idea after we had our first conference. We sort of had this conference that went really, really well, and we had close to 100 plus allied health that were there, and that went really well. And then the idea of creating these short webinars on very pertinent subjects was also launched. So we were doing this quarterly or every 3 months or so, where we would have 3 or 4 specialists branching up and talking about a specific topic. We did one on headache, where we would say, what are the basic treatments? And as things can get complicated with headache in certain patients, well, we were introducing more and more different types of therapists, and we had a nice session right across, 15 minutes each, lasting about an hour. And these are all available on our website. So I think it's done a great job to introduce and let our allied healthcare and patients good basic information on headaches, vestibular, vision problems, neck problems, and we kind of took them into little segments like that. And I think up to now it's been successful. We would like to disseminate this information even more and get it into everybody's hands, but it's a slow process, and I think we're coming around with a good concept.
So if I'm a healthcare provider in Manitoba, how can I become involved with Mackin? How does that work? Do I have an access point? What kind of qualifications do I require if I want to become part of the Mackin network?
Correct. I think anybody can be part of the network as long as they work with us. I think the goal is working with us and having a communication. When I say us, it's a large network. So first of all, we have our website, Mackin or macn.ca, and there's a lot of good basic information on there. And we can also be reached through our website and also through an email address, and we can answer some basic questions that way. But I think there's a list of several therapists that work directly with us. So Mackin is a information area. I don't think we necessarily are a group that has to do the diagnosis, but we are a group that actually helps to give the right information out there. So our website is well developed for a lot of questions. There's a good Q&A section, what to do, what not to do, and a lot of resources there. Plus, you can also reach us just with some simple questions and we'll get back to you.
Well, thanks, Patrick. I've learned a lot about the organization, even more than I had before I was a member. Anything else you'd like to wrap up with to the people of our province about Macken?
Well, first of all, I want to thank you, Neil, for this opportunity, because if people understand that concussion can be treated simply and have a really good success rate, but it needs to be done in a very relaxed manner, I think that's a good start in getting that information out. So I think we still have a lot of work to do. A lot of our primary care practitioners may not be fully educated on how to best treat concussion, and same thing with our allied health. So we want to be a tool for them to increase their education. So we'll hopefully have these podcasts, which will help, and maybe some more webinars and some conferences, and just to try to reach out to people. So that's kind of, I think, our plan in the future.
Hey, thanks, Patrick. So, ladies and gentlemen, I hope you enjoyed this brief chat that I had with my friend and mentor, Patrick Fredette. And we look forward to having more opportunities to discuss about many topics related to concussion in the near future. Take care and bye-bye.